Hello, and welcome to this education session on medication administration through a peripherally inserted central catheter, or PICC line, central intravenous line, and a subcutaneous Port-A-Cath. So we've had some recent care map updates in regards to our scope of work when it comes to these devices. So with this, a new update was injection of the peripherally inserted central catheter, or a PICC device/line. Underneath our scope of work here as an EMR, you're not able to access these devices. As a PCP with extra education, you may do that. If you're an ICP, you can go ahead and get medication through this line. So a PICC line itself is a peripherally inserted central catheter, which is why it's called a PICC line, is a tube that's placed in a large vein in the inner elbow area. It's threaded through the vein to rest just right above the right atrium of the heart. The other end of the catheter stays outside the body. That's how we're able to access it. PICC line is a safe, stable, and effective way to deliver IV medications. And these can stay in the body for weeks or months. And it really saves our patient a lot of grief by alleviating the need to give them multiple IV sticks and just multiple access to their veins. So another reason why patients may get these is some medications are caustic to the vasculature. So PICC lines allow these medications to be delivered to larger vessels that are less likely to be damaged by these caustic medications. They're also versatile because patients requiring long-term venous access for conditions such as nutritional deficiencies or IV antibiotics, they can use these. So again, they're not constantly accessing it through an IV site. So there's different parts of a PICC line. So as you can see here in point 1, this is the internally inserted line. This should be placed in a large vein without contacting the vein or the heart wall. The ideal placement of this line is between the lower third of the superior vena cava and the cavio-atrial junction. Then we have the exit side of the catheters. This is the part that we actually access that goes into the body. So this may have a medicated disc or a biopatch over the insertion site to prevent bacteria from entering the body. So as you can see here, we've got a few different types of biopatches here. So those are just put on there to absorb any exudate or just to cover the wound, any type of lines really. So it's there to reduce local infections, any catheter-related bloodstream infections, and skin colonization of microorganisms. So it's basically just there to keep it clean. So other components we have of our PICC line. So we have the clamp itself. So when the line is not used, the line should remain clamped. That way it prevents blood from draining out the line. Some of the lines may not have this clamp in place, but they actually have a valve inside the line which prevents blood flowing out of the tube. So if you're going to be doing this, usually in a healthcare setting, because obviously we're not going to be initiating these, talk with the care providers if you don't see a clamp, if they have that valve in place to prevent backflow, or just maybe the clamp is missing. So just confirm with the caregivers. Other components we have there, so the fourth part is the access cap and the lumens. So PICC lines have 1 to 3 lumens, which allow for medications to be attached and flow through the line. These lumens have caps on them that may be blue or orange to help keep the line sterile. So as I said before, you may have multiple lines, so it can be up to a triple lumen PICC lines. And with multiple lumen lines, each separate lumen is enclosed within a single sheath, making the line appear to have only one line, but each line allows for separate infusions through an individual lumen. So each lumen is labeled at the line's proximal end. So we have the distal, the median or the middle line, and proximal. And these are reflecting the internal exits of where the fluids or medications come out inside the patient. So the distal lumen exits at or closest to the line's internal tip. So this lumen is usually reserved for blood sampling and transfusions of crystalloids or colloids. The median or middle exits an opening alongside the side of the catheter, often about 2 centimeters from the tip of the internal end of the line. And this can be used for transparenteral nutrition or medication administration. And the proximal lumen exits at a side opening furthest from the tip of the internal line, often about 5 centimeters, and can be used for medication administration, blood sampling, or medication therapy. Again, when we take these patients, if we are looking that we might have to give medications through these lines, confirm with the caregivers the correct port to use, confirm the medication, and just make sure that you have permission from the caregivers to give medications if you need to, or if it's just cap them and not worry about it. But definitely confirm before you take your patient on your transfer. So if we end up needing to give medication through these lines, we're going to assess the PICC site entry for swelling, pain, history of fever, or if they're unwell after having the line flushed, because sometimes these patients have these at home. So if we're doing it as an emergency situation in a home, not necessarily in like the hospital, we want to make sure that the site is still valid, and that could be the reason why they're calling us. So like it shows here, we want to make sure that there's no swelling, pain, discoloration. So you can see the pictures, there's redness, there's swelling around the site, the actual insert site's looking rather inflamed. Obviously, this means we cannot use this line anymore, and these patients should really get checked out at the hospital because that could a really bad infection. We want to confirm, again, like I said before, make sure we have the correct medication. We're using the correct lumen, so double check to make sure you're actually grabbing the right lumen to insert the medication. Because if they have multiple, we want to make sure we're not putting it into the wrong line. And this isn't necessarily a sterile technique, but it's definitely a clean procedure. So if you're going to give medications through the central line or the PICC line, make sure that you put on clean gloves. We don't want to risk introducing any bacteria or introduce any kind of infection into their heart. We're going to get some equipment together. So we're going to get some saline flushes. We're going to get our syringes to drop our medications. We're going to get some alcohol wipes, and we're going to drop medication as prescribed. So the first thing we're going to do is we're going to move the cap off the line, and we're going to clean the selected access port with a swab for at least 15 to 20 seconds, and we let air dry until completely dry. It's very important we just let it air dry. We don't want to blow on it or wave it around or anything like that. Just let it naturally dry, and if you haven't drawn up your meds, now would be a good time while you're waiting for it to dry. We're going to check the patency of the line. So we want to make sure it's actually working because, again, like if it wasn't flushed properly last time to use it, it may be clogged. So we want to check that first before we start trying to put medications in. So to check the patency of the line, we're going to make sure we're just going to flush the line and drop some blood, but we want to make sure whatever we're doing, we do not touch the port itself with your hands. So what we're going to do is we're going to take one of our 10 cc saline syringes and we're going to attach it to the port at the end of the line there. So once the syringe is attached, we're going to draw back a bit and we're just going to wait until we see blood in the line. You don't need to draw blood all the way back to the syringe. It's just drawing back enough so you actually see that there's blood in there. So flashback in the syringe itself. So if you draw too much back, it actually puts patients at risk for creating an occlusion if you don't flush it back in correctly. So then what we're going to do is we're going to flush the saline back into the line slowly over 3 to 5 minutes. So again, it's a very slow push. If medications or fluids are given too fast and under too much pressure, this can actually cause a fracture of the catheter itself. So when we want to flush the line, we're going to use a turbulent flush. It's a stop-start vigorous motion intended to clean the inside lumen of the line, which you would not get with just using a straight flush. So this is also known as push-pause push method. So you push 1 or 2 mLs of saline, and then you pause and you push another 1 or 2 mLs of saline. And again, we're going to do this slowly. We're going to make sure we're not putting too much pressure, as this can dislodge the actual catheter placement and cause it to flip into the internal jugular vein. Once completed, make sure you don't touch the access ports. We're just going to grab below it, and we're going to take off the actual syringe. If you're unable to actually flush that line, you can't use it, and ensure to tell the receiving facility of the patient that we weren't able to flush the line, that it was clogged or it just wasn't working for us. But if it does flush appropriately using that technique, we're going to take another alcohol swab and we're going to clean the port again, being very careful not to touch anything we don't need to touch. And then we're going to slowly administer medication as advised by the facility, ensuring to use the correct port. So again, make sure you're using the right port. We're not using one we're not supposed to. And again, this is going to be a very slow push because we don't want to risk flipping that line up into the internal jugular vein. So this is very slow and steady, again, over 3 to 5 minutes, no matter what the med is. Once the medication administration is complete, we're going to remove the syringe and flush the line with saline. So again, we're going to use the same turbulent flush we did before with the push-pause method, and we're going to make sure that the line is flushed appropriately. One thing we have to keep in mind, though, is while we're doing this, we need to maintain positive pressure when the syringe is removed. So that way, if they do have the valve inside their line, this prevents any blood flow back into the line. So as you can see in the video here, we just slowly push, pause, and then we push, pause, and as we push, we take it off, and that maintains pressure inside the line. If they have clamps on there, we just make sure the lines are clamped after we remove that syringe. And then we're just going to document what we did, the procedure, why we did it, and if we were given medication orders by the sending physician, we're going to document that as well. So that's the use of PICC lines. So central intravenous lines. So with this one, again, with our scope of work, as EMRs, you're not able to access these. As PCPs, you can with extra education, as well as ICPs with extra educations. The big thing of note here is this is to be done only in emergencies. So this, if we are at a home and our patient's coding on us, and they have a central line in place, we are only to be using it if it's the absolute last choice. So again, IO access would be preferred in emergency over using these. So with that, a central venous catheter is an indwelling device inserted into a large central vein. Most commonly, that's the internal jugular, the subclavian, or the femoral, and advanced until the terminal lumen resides within the inferior vena cava, superior vena cava, or the right atrium of the heart itself. The indications for central venous access is often broad and situational. So there may be need for multiple infusions that may be incompatible with peripheral IV access, such as pressors, parenteral nutrition, chemotherapy, and like I said before, other caustic medications that would damage the veins otherwise. It might just be put in because they're not able to get venous access in emergency situations where it's just there's no veins, so they go this route instead. So with the other things we're looking at, if they're trying to do certain therapies such as hemodialysis, continual renal replacement therapy, or just if they want to do hemodynamic monitoring, including central venous pressures. It could also be used for putting in transvenous cardiac pacing, intravenous stenting, thrombolytic therapy. So there's a lot of reasons why these might be put in place. So there's two different kinds. There's tunneled and there's non-tunneled. So the first one here is a non-tunnel catheter, and it's basically, they're very much similar, but a tunnel catheter in terms of general function design, but it differs greatly in terms of its use. So unlike a tunnel catheter, a non-tunnel catheter is inserted directly into the vein without passing under the skin. So as you can see in the picture there, it's just going directly into the vein there. These also consist of a long, thin piece of tubing that allows medications fluid to pass through. They may have one or more lumens for the transfusion of different fluids, and they may have certain attachments at the end, but are usually simpler in their design when compared to tunnel catheters. So these ones are easier to insert overall and are designed for shorter term use. Again, these are probably going to be more so the emergency access ones versus tunnel catheters, which I'll talk about in a second. They're helpful for providing temporarily providing a patient with certain fluids versus like standard IV therapy, or for carrying out tests and checks of the patient's blood pressure and cardiovascular system. So again, they can use these for monitoring and or medication, fluids, any kind of administration. So then we have tunneled. So a tunneled catheter is a central venous catheter which is placed subcutaneously or right underneath the skin. So before inserting a tunnel catheter, a doctor will typically make an incision at an insertion site, which is often in the chest, and then use a tunneling device to form a tunnel under the skin that the catheter passes through. In terms of their design and structure, tunnel catheters consist of a piece of long, thin tubing. They may have one or more lumens or channels by which fluid, blood, and medications can go through, just the same as the non-tunneled ones. These ones, though, they also usually have a cuff, and this is a small antimicrobial attachment near the entry site that helps to hold the catheter in position and reduces the risk of infection into that site. So again, they're called tunnel catheters because they create a tunnel. The line is put in through the tunnel, through the skin, and into the venous system. These ones are typically designed for long-term use, or at least a couple weeks, or up to several months if required. And it may be used for a variety of purposes, including antibiotics, chemotherapeutic drugs, or for internal monitoring. So again, the actual design of the catheter is similar to the PICC line. The main difference in its components is the cuff in a tunnel catheter, which will hold the line in place. So with central venous catheters, they come in many different styles based on what they're needed for. So again, this is where if we're going to be using them, we have to make sure we talk to the care providers and make sure that it's even an option for us to give any fluids or medication through these lines, because they come in double, triple, quadruple, and quintuple lumen catheters. So obviously we've got a lot of choices there, and it's not something we just want to go into blindly and just grab one and start pushing meds through. We have to make sure that we're aware of what we're doing, because there may also be things such as introducer lines, which are used to insert venous pacing wires or used for hemodynamic monitoring. So obviously we can't push meds through a hemodynamic monitoring line. So again, check with the sending facility if you think it might be an issue that you might have to access it for some reason. Okay. So to administer medication through a central line, it should only be done in emergencies as per our scope of work. The procedure for medication administration through the central line is basically the same as administration of medication through a PICC line, like we just reviewed. But again, always check with the sending facility staff. Some lines may require heparin flush after medication or saline administration has been administered to prevent coagulation of the line. So they may not want us touching it at all just for safety purposes, or they might be using it for different reasons that we might think. And so again, just a lot of checking beforehand before you would even consider putting medications through here. So have that conversation with the care providers. If you do end up giving a medication to this line and you didn't put weren't able to give heparin flush afterwards, make sure that you flush it as per we discussed with the PICC line admin, and tell the receiving facility as soon as possible, because they'll probably want to put some heparin in there. Next thing we have is we have our injection into subcutaneous Port-A-Cath. And again, this one is strictly for only emergencies, like you have no other options whatsoever. So a Port-A-Cath is a device used to draw blood and give treatments, including IV fluids, blood transfusions, or drugs such as chemotherapy and antibiotics. This port is placed under the skin using the right side of the chest, and it is attached to a catheter or thin flexible tube that is guided into the superior vena cava. A needle is then inserted through the skin into the port to draw blood or give fluids or other treatments, as you can see in the picture on the left there. A Port-A-Cath may stay in place for many weeks, months, or even years. It's also just commonly referred to as a port. So as you can see in these pictures here, so once it's healed, it'll look or feel like a small bump underneath the skin. So the patient at the bottom there has it in his arm. The one on the left there has got it in his chest on the side, and the patient at the top there has got it more anterior at the front of their chest. So a Port-A-Cath in place and an access needle being inserted is what we're looking at right here. So with that, again, you can see that it's not a regular device that's going to access this port that we carry on the ambulances. The portal itself is made of a special self-sealing silicone and can be punctured repeatedly by a needle before the material becomes compromised, and this helps reduce the chance of infection. So again, if the patient's going to be accessing this quite a bit, it just gives them more safety from getting that needle stick infections. And as you can see here, they do have a special device to place it in. So they may have a port that may be single or double lumen, or they may have what's known as a power port. Again, this is stuff to talk to the healthcare providers before you even think of accessing these. So talk with the staff at the hospital or the caregivers on scene about, ask them about the patient's port. So one thing to keep in mind, again, this is why it's really important we only access these in absolute emergencies, is that they are supposed to use special needles on these ports or we can damage them. So we have the Huber point needles, which are thought to be non-coring, are usually recommended for puncturing of implanted drug delivery devices, such as these ports and specific types of pumps. So as you can see in the picture on the right there, we have standard needle and Huber needles. So the standard needle in the picture at the bottom there shows what happens to that silicone when we poke it. It just wrecks it. So it damages right through it. So we want to make sure we use a Huber needle because it's just designed not to damage the port. The only needles we are really supposed to be using on the ports is a Huber needle. If we obviously don't carry this on the ambulance as a regular piece of equipment, so we straight up have no other options. You can use a standard needle, but I would strongly recommend calling online medical before you do that, and try to seek any other ways to give medication administration instead of using that port. So just some other examples of Huber point infusion sets. So they come in different shapes, different sizes, but again, you can tell it's got that angled needle there. It's got a special hub to it. It's not something we regularly carry on the ambulance, but these are what are required to actually safely access the port. So if the patient does have one of these devices in already, we can give medications through it. Again, we don't want to use our just regular IM needles. We'll wreck their port. So again, it's not a sterile procedure like we were talking with the other lines as well, but it's definitely, we want to keep it as clean as possible so we don't introduce infection. So we're going to put on a clean pair of gloves and make sure we only have to touch what we need to touch. So with this, to give medications, we're going to attach a saline flush syringe, open the clamp, and then pull gently back until blood is seen to verify needle placement. Again, all you need to see is a little bit on the line. We don't need to draw it all the way to the syringe. Then, like we talked about before, we're going to use that same push-stop motion to inject the saline. And we're going to maintain positive pressure by inserting all the fluid except for the last ml or 0.5 mLs. Just make sure you have some fluid left in the line. We're not going to push all of our fluid out of their syringe. To give medication, we're going to cleanse the site with alcohol swab, allow it to air dry again, and then we're going to give our medications as appropriate or requested or informed or told by medical direction or the sending facility, and we're going to give it over the appropriate time period. So again, we're going to give it a nice slow push, about 3 to 5 minutes, because we want to make sure we don't dislodge anything. Once completed, we're going to gently flush the port with 10 cc's of saline. Then the lock should be flushed with heparin after you give that flush. Again, we don't carry heparin, so if you do use this, make sure you inform the receiving facility that we have to give medication through the port. So we want to maintain positive pressure again. So when we flush it, don't empty out the syringe. Just make sure there's some fluid left in the syringe when you take it off. And that is our educational review on central line medication administration. Thank you very much.